Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise, and this is your best place to go for urology healthcare education. And we're still supporting the Prostate Cancer Awareness Month. That's why I'm wearing my blue. So join us as this support. We're going to be doing all prostate related subjects. So today's no exception with that. If you're watching us live, great. Glad to have you on board. If you're not, you're watching us and you're on demand later on, no problem. That's what we're here for. But if you want to watch us live and be part of the show, be sure to check out our website at uronurse.com, the best place to go for all of our past episodes. And we've got a bunch of them, 111 episodes. Plus, you can sign up for the live episodes on there. Hey, maybe you want to check out UroNurse on the on demand. No problem. Just go to our podcast on UroNurse Plus, pick up any of your favorite podcasting places, and you'll be able to get us. Also wanted to get a quick reminder that the SUNA conference is coming up next week. We'll be out there live. You'll be able to meet and greet us if you want. I encourage you to do so. And we're also going to have the online episode. We're going to be going live for our episode out there at 10 o'clock Eastern time, 9 o'clock Central, always the same time. Also, the SUNA Foundation's got their online raffle. Be sure to be a part of it. Chicago Metro SUNA has got a big prize their grand prize that we're donating, an Amazon gift card. So be sure to enter in for that and other things that's going on for the SUNA Foundation. This week, we're going to, like I said, stick to our prostate cancer awareness, and we're going to be doing a survey that everybody received and that signed up for our email. And thanks for all of you that filled out the survey. It's going to make an interesting show. So let's go ahead. Let's bring in all of our guests here today. Hey, welcome everybody. Welcome to the show. We got John and Lori joining us. John, why don't you go ahead and give us your introduction?
Well, good morning, everyone. I'm passionate about being a helper to urology practices and get them to reach maximum clinical and financial efficiency. And to that end, I created a free Facebook group called the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for your benefit. And as a modern day Robin Hood, I take from the information rich and give it to the time constrained poor, people like you, the listening audience. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and just how to run your practices more efficiently in an era of declining reimbursement and rising overhead costs. If you will be at the South Central section of the AUA meeting in October and Urology Advanced Coding and Reimbursement Seminar in December, please say hello. I will be there and look forward to interacting with everyone. I'm John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today about prostate biopsies. Back to you, Vic.
All right. Thanks, John. And Lori, give us your introduction.
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology since 1998. And I currently work for Northwestern Medicine in Winfield and Geneva, Illinois, and very excited about today's topic, Vic.
All right. And of course, as I said earlier, my name is Vic Sinise. I'm the host and producer of the show, and I'm the guy who came up with the survey. So I'm going to be going over the survey, but it's going to be all of our experts that are going to be joining us and you, the audience. We need your participation in this too. So any questions, comments, go ahead and put those in. Lori will be bringing those up on screen for us, but let's go ahead and get right into our show. And here we go. That's right. The survey says prostate biopsy strategy survey. This is the one you guys have been filling out for us. We appreciate all the work you did getting that information in there. And we're going to cover all these questions right now. And let's start with our first question, which was, what type of prostate biopsy do you offer? So what are people doing out there? Probably no great surprise that transrectal ultrasound guided prostate biopsy was the number one thing. But it's catching up now. MRI, ultrasound, fusion, a lot more people out there doing that. MRI guided, perineal biopsy. It's starting to really climb up the ladder. And then there was one I never heard of before called cognitive guided fusion biopsy. So let me just review a little bit about what we're talking about, and then we'll get to our conversation. So the picture on the left is our ultrasound probe, transrectal, through the rectum going into the prostate, the traditional one. Up above on the right top, we see the perineal approach. You still have an ultrasound in the rectum, but you take those samples through the transperineally and avoid going through the rectum. It's gaining a lot of momentum right now because of the decrease in risk for such things as rectal bleeding and infection. And then the other one that I hadn't heard of, and I'll bring in the experts to see what they've thought or what you guys have heard of, cognitive. It makes a lot of sense. It's not really a true fusion biopsy. What you do is you take and look at the MRI, kind of see where that lesion's at, and mentally in your brain recognize where that's at, and then go ahead and use a traditional transrectal ultrasound to locate it based on what you saw on the MRI. Does that make sense to everybody? John, had you heard of it before? The cognitive?
Yes.
Did I do it justice describing it?
Yeah, you did a great job. Yeah, seems like there may be some confusion because MRI guided is still transrectal guided.
Mm-hmm.
So,
well, and if you wanted to learn more about the MRI, we did have episode 93. Dr. Pullman actually talked about the MRI guided prostate biopsy. So it's a good episode to go and check that out for more information. But the cognitive one I hadn't heard of before.
Yeah, his Dr. Pullman's discussion, if I remember correctly, his episode was about MRI guided, except he was doing the MRI guided using a special in-office MRI device.
Right.
Not portable, but smallish MRI in the office. So that was also a unique aspect of that particular form of MRI fusion guided biopsy.
Right. That one, they did not use transrectal ultrasound. They just used the MRI, where the fusion is a combination of still transrectal ultrasound. All right. Lori, any good comments coming up?
Not so far. Wake up, people.
I see a couple up there. It must be all the hellos. We always get a bunch of those. All righty. So let's go.
Oh, wait, I'm sorry. Susie Swain had mentioned. Oh, wait, we've got comments. I'm sorry. I missed. So Heather Hansen.
Lori didn't have her coffee this morning.
Oh, it's me that needs to wake up, apparently. So Heather Hansen said we perform fusion and core transrectal in the clinic, transperineal in the OR, but just started. And Susie said regular cognitive prostate biopsy and fusion biopsies.
Wow. All right. So it's starting to grow. Makes sense. All right. So our next thing is I asked, where do you actually do these biopsies? And gave some options: office, hospital, freestanding clinics. And we can see that the bulk of the prostate biopsies are actually done in the office, which makes a lot of sense. The OR, I think, is getting used more and more with some of these other procedures, especially the expensive things like MRI and stuff that they can get in a hospital setting more freely than putting it in a clinic. But freestanding surgical centers, etc., are being used quite a bit. So I don't think there was any great surprise here. Office seems to be the leader still in prostate biopsy. John, you're doing your all in the office or mostly office?
Yes. So the viewers who are looking at the slide may be wondering why the numbers don't quite add up. It's because the survey answer people who answer the survey can pick multiple answers. Right. So a lot of practices are doing some in the office, some in the surgery center, some in the hospital. That's why the numbers don't add up perfectly.
Yep.
You can perform all sorts of biopsies in the office if you have that low magnet, small magnet biopsy device or assisted biopsy that you can do in the office per Dr. Pullman's episode. Or if you have, so some states allow you to have in-office sedation, IV sedation. So in Arizona, I can have an anesthesiologist come into the office and provide sedation. So if you have the equipment, you have the space, you can perform transperineal biopsies, which are usually done in the operating room because of the potential discomfort. Some practices who don't have in-office IV sedation They are also, some of them are doing transperineal by applying something like Emla cream to the perineum and then doing some perineal blocks so that they can provide that biopsy in the office. So things are evolving.
Yeah. And Lori, what's your practice doing?
So we do actually, I mean, we used to do obviously transrectal biopsies all the time in the office, but we did move to transperineal biopsies. We currently do all of our biopsies in the OR right now.
Gotcha.
But we are planning to move those to the office at some point here in the near future.
And our practice does the transrectal ultrasounds and the fusions in our office. And we do have the ability to get anesthesia in for those. So that helps. All right. Our next question is, who performs the prostate biopsies? And I don't think it's any big surprise the bulk of these are done by physicians. Again, as John pointed out, when it says select all that apply, we're going to get over 100% because I often are allowing for multiple answers. So mostly physicians, but we're starting to see the PA and nurse practitioners moving into this area. And I think this is probably a great area for them to get involved in with the initial biopsies. So not a big surprise there. And that led me on to this next subject, which is we're doing the biopsies. What pre-op antibiotics are being used? And I was, again, select all that apply. I offered also, you could write in what you're doing if it was different than what I offered, because I said Rocephin or ceftriaxone, quinolones, penicillin, Bactrim, or nothing at all. And kind of a surprise, there was somebody who said they didn't have any antibiotics used. And then some of the other ones are similar to that, but gentamicin was thrown in there. So we'll kind of go into some of the options just to discuss it. So Cipro is probably no big surprise for those of us that have been around as long as I think most of our group here. Back when Cipro first was made, came out into the market, the Bayer Pharmaceutical Company did a great job of coming into the office and just giving us handfuls of samples. And hey, you guys need to use this drug. It's the best drug for prostate issues. It's great coverage. It gets great penetration in the prostate. All true. But the last statement was the false one. They said, and you'll never see resistance to this drug. Did you hear any of you guys hear that that talk where they said never hear resistance?
Yep.
And I kind of chuckled when they said it. I'm like, okay, we'll see. Well, of course, we know that didn't happen, so it didn't hold up. But it's not a big surprise that quinolones became the number one choice for most people for prostate biopsies. And I mean, for a number of years until resistance started coming along, it really was excellent coverage. I mean, we had very few infections afterwards, but we do know that this E. coli resistant to the quinolones started to happen. So other things like combinations of antibiotics were thrown in where they would add Cipro and do gentamicin on top of it, or sometimes just gentamicin by itself. Now, I can tell you our go-to drug, at least in our area, the one that seems to work the best is ceftriaxone. Nice thing about it is, although it mentions IV there, it can be given IM. So you don't have to start an IV on a patient. You can just inject them ahead of time. And we've had very, very few breakthrough infections on that. But again, so far, gentamicin, again, we used that for a while. It was really working. And then all of a sudden we started catching some resistancy. So it doesn't, what works today may not work tomorrow. And then interestingly, this concept came along, rectal swab. Anybody doing the rectal swab in their office? Bringing my experts in here.
No.
Lori, nope, not, yeah.
Negative, negative for rectal swabs, no.
Yeah, so they really were kind of big a while back. Actually, I was part of a group that was looking at the infections for prostate cancer. I mean, for prostate biopsy, with the AUA and SUNA doing a combined white paper. And let's see here. Why am I not getting? There we go. And one of them was to do a pre-op rectal swab culture, see what bring the patient in ahead of time, see what drugs are going to be best to use, and then target the prophylaxis. Again, as we saw from our basic audience and audience out there, if you have any comments, if you guys are doing it ahead of time, I'd like to know it. So feel free to put that into the comment box. But I don't think it's really picked up a lot of traction. I know that there are some places that still offer it, but it just doesn't seem to be popular. Now this was back in 2011 that I did the studies that were showing the risk factors and why they were doing it, the cultures. So then there's this other thing that came out called rectal antisepsis, where you could actually, they claim you could sterilize the bowel, just, don't have anything there to cause an infection. And I'm not so sure about that. So I did do some research. We don't do that, but here's what's involved with that. And then we'll discuss it.
The overall goal of this procedure is to reduce infectious complications following prostate needle biopsy by pre-treating the rectal vault and perianal area using a povidone iodine slurry.
We first came up with the idea for this method based upon observations that infectious complications following prostate needle biopsy were increasing despite patients taking adequate antibiotic prophylaxis. The main advantage of our technique versus other methods, such as targeted antibiotic prophylaxis, is that our method can be used in every biopsy patient without the need of culture processes and adjustment of antibiotic regimens.
Prepare for the examination by putting on examination gloves. Now, lubricate the rectal vault and perform a rectal examination to investigate the areas of the prostate which will be focused on by the transrectal ultrasonography. To make the working povidone iodine solution, first pour 15 milliliters of stock 10% povidone iodine solution into a sterile container. Then, add 5 milliliters of 1% lidocaine gel to this basin and mix them together with a cotton applicator for 15 seconds to create a slurry, thus completing the PIRP. Next, open up a 4 cm square sterile gauze and soak it in the povidone iodine slurry. Then, insert the gauze into the rectal vault. Only a small tail of gauze should be left emanating from the anus. After 2 minutes, remove and discard the gauze. Next, use a disposable gynecologic swab to paint the perianal area with the PIRP solution. Once finished, dispose of this swab. Then, soak a fresh gynecologic swab in the povidone iodine slurry and insert it into the rectal vault approximately 3 centimeters into the anus. Paint the anterior rectal wall with this swab.
An essential component of this operation is painting the anterior rectal vault with the povidone iodine preparation, because this is the mucosal surface that's penetrated by the needle biopsy probe.
To maximize the exposure of the rectal mucosa to the PIRP, repeat this process at least 3 times. Keep using the same swab to paint the back wall of the rectal vault repeatedly. Very importantly, proceed with letting the PIRP solution dry for 2 to 3 minutes so its bactericidal effects can have their full effect. Then, proceed with the standard transrectal ultrasonography and biopsy. This PIRP technique has been in practice since January of 2012 on 165 patients. Thus far, only 1 patient has experienced an infectious complication in the form of systemic sepsis. A patient population undergoing TRUS-PMB, which only received oral antibiotic therapy, serves as a control population. 22 of the 515 patients in this cohort experienced an infection. 17 of the infections were in the urinary tract, and 5 experienced clinical sepsis, defined by a fever with a positive blood culture. Overall, integration of the PIRP technique into clinical practice was associated with a significant reduction in post-biopsy infections. Rectal cultures were performed in the 165 patients before and after PIRP to document changes in rectal vault microorganism colony count attributable to the treatment. Overall, a very significant 97.2% reduction in microorganism colonies was noted after PIRP administration.
All right. Well, experts, your thoughts.
Well, so Heather had mentioned that they don't use any swabs, but Susie actually says that she does have a urologist that uses the betadine slurry. I
John, any
don't.
thoughts?
I mean, ours don't.
Yeah.
I mean, nor do I really even heard. I've never really actually heard of that. I guess what are the cons? If it's been out since 2012, why hasn't it flourished? I guess is the question.
Yeah, that's true.
Yeah, always have to be mindful that it came from a single institution. And as you know, the local antibiogram varies. That's why they call it a local antibiogram.
And they did state that it was compared to oral antibiotics. I'm not too sure how many people are just strictly giving an oral antibiotic anymore for biopsy. What are you guys using in your clinic, Lori?
Well, we don't. Obviously, we do them in the OR. So,
Oh,
but for most of our, other procedures, we use ceftriaxone injections.
yeah. And John, in your
I'll bet
practice?
you- I'll bet you a lot of practices are still using oral antibiotics.
It's interesting. 'Cause I got some other facts I'm going to go over with you then to kind of maybe persuade people to quit using or just strictly oral. New risk factors discovered. These were not newly discovered, by the way. This was stuff I found in my work with the AUA group. So antimicrobial exposure within 6 months prior to the biopsy showed greater risk of quinolone resistance. So if you were on a quinolone before a biopsy, chances are that it would not work as well. This one kind of surprised me. Hospital employees and their family members documented that there was a greater multi-drug resistance sepsis found in those groups. And because, again, exposure to, I guess, patients that are on multiple antibiotics. Recent international travel. So if you're somebody who likes to travel out of the country, you have an increased risk of harboring this, drug resistant bacteria in your bowel. That makes kind of sense if you haven't traveled out of the country. America's where you go to your pharmacy with a prescription to get an antibiotic. If you're in one of these other areas, like I've gone on several cruises, you can walk into the local pharmacy and pick up Cipro or whatever you want pretty much from the cabinet on your own. You don't need a physician's order to get that. So probably makes sense why that would be the case. Let's just go into anybody's further thoughts on those risk factors being something that they thought of before or heard of before.
Yeah, I remember reading those studies, and I always think, okay, well, correlation does not mean causation. So always be mindful.
Yeah.
Well, Vic, I'm sure, or John, you probably both remember how we couldn't even get Cipro for a while because of the whole anthrax thing way back in the day.
So funny.
Yeah.
That's exactly what I thought of.
It kind of evolved since then, in my opinion. So
yeah. All right. So let's go on here. Again, comments. If you guys have comments back, anyone watching want to say anything, go ahead. So the next thing I wanted to ask about was aspirin therapy. And I asked, do you have patients stop taking aspirin? I made the choice of allowing 81 milligram baby aspirin versus full strength aspirin. So for the question, yes, whether you stopped it, no, you didn't, or did you allow baby aspirin? And so we could see that about the majority stop aspirin, full strength aspirin. Some say no. Baby aspirin, we saw, 20% allowed that. So I thought, well, let's see what the AUA has to say about that. And for full strength aspirin, 325, their argument was, look at the risk, cardiovascular risk, the reason people are on aspirin. If it's low risk, they should be discontinued 5 to 7 days prior to the biopsy. If they're high risk, patients' risk may outweigh the risk of stopping the aspirin. So they always say, of course, discussing with a cardiologist is the most important part of it. And I don't know, do you guys normally refer them back to their cardiologist when they're on blood thinners to find out what they want you to do? Lori said, shaking her head, yes. John, do you send off to cardiology or do you just stop?
Yeah, if the patient's on anticoagulation, Aprexaban, Eliquis, it's Coumadin, etc., I don't know, obvious, but I want to say, obviously, we send them to the cardiologist to inquire if the patient can be discontinued on anticoagulation and also when they want the anticoagulation to stop and when to resume. As far as aspirin goes, we encourage the patients to stop all aspirin and NSAIDs if possible. That said, if the patient were to forget, say on the day of the biopsy, the day before the biopsy, they said, "Oh, I forgot I took a baby aspirin," I would not cancel the prostate biopsy. I would proceed with the prostate biopsy. The risk of bleeding from, of course, the worry is bleeding. The risk of bleeding from a transrectal ultrasound guided biopsy or perineal biopsy while on aspirin, baby aspirin, one dose, it's pretty low.
Yeah. Good point. And I know some of the cardiologists that we recommend they go back to their cardiologist, and they'll put them on, if there's severe risk, on a bridging with Lovenox, something that can be stopped just right before the biopsy, and that works out really well. So I did look at what the AUA had to say about baby aspirin, because that's been a change in policy. Before it was any aspirin, stop it. But a lot of them are saying, go ahead and continue aspirin therapy if it's 81 milligrams, that the risk of a severe bleed is very, very low. And I think, as John said, somebody's just taking on a single aspirin, that's not high risk like being on it every day. So we have most of our urologists that I work in a group of 5 have said, go ahead, just do it if they're on baby aspirin. And we've had I can't say any difference between people that stop or not on aspirin versus 81 milligram. I haven't seen a difference. Anybody else have any differences that they saw with baby aspirin bleeding? Or seems like it's kind of a non-factor. All right. And any comments coming in on the comment box?
Going back to the antibiotics, Heather had mentioned that patients are given oral antibiotics prior to biopsy, and then also an IM injection of Rocephin the day of the biopsy. And I agree. I think we see that a lot too.
Are you guys doing multiple days of antibiotics, or is just single shot? John, do you guys put them on for long term, or just a single injection type treatment?
The oral dose before and oral dose after.
Okay. And then Lori, you said there's done.
Well, our procedures, we don't do the biopsies in the office, but our other procedures don't require the oral antibiotics. We just do the one shot of Rocephin prior. So.
And that's what we do, is the one, if it's Rocephin, if they're allergic to cephalosporins and we have to use something else, then typically, because it doesn't last as long, we'll put them on an oral afterwards, and both have done well. So, all right, let's go on to our next thing. So this is going to be talking about bowel prep. Do you do a bowel prep? And too many buttons here. So I asked, does your institution require a bowel prep? And most do, almost 70%, but almost 25% don't require a bowel prep. So kind of interesting. Get some of your thoughts on that. I'll tell you a quick story. So after I was part of this white paper, I was asked to give a talk on this to our SUNA group. And the SUNA, besides being, throughout the country, does have a lot of international guests that come in for the talks. And I happen to have some people from England in the audience. And then when I spoke about this bowel prep, that, we use a Fleet's enema or some bowel prepping agent. After the thing was over, they came up to me and said, "You Americans are crazy with your bowel preps. You can't prep a bowel. It's impossible." And I'm like, oh, okay, well, there is a difference between Americans and people that aren't American. Americans don't want to miss work. So really, my thought is the only thing a bowel prep really does, I can't disagree that it's not sterilizing the bowel, but it does keep a constipated patient from having stool in your way so that you've got to reschedule them. And that's the reason that we do it. Well, England, they don't have to have such a big work ethic like we do, I guess. So they don't mind canceling and rescheduling people. So that's my thought on it. What are your thoughts, John?
Yeah, it's kind of like all the prep that you do in the vagina of the rugae and the bowel. You can't really sterilize those environments perfectly. So you do the best you can. As far as full bowel prep, like drinking a ton of Go Lightly or something like that, I think that's probably overkill for transrectal ultrasound guided biopsy. But I can certainly understand the merit of a Fleet enema minimal cost as far as missing work, and minimal cost as far as using the product, and minimal risk of injury. So I think fleet enema, if you want to do one, is reasonable.
All right. Lori, any comments coming in on that? I see a few comments coming up there.
Yeah, so we have Susie that says one of the urologists says a fleet enema prior to biopsy makes biopsies more painful for the patient. Heather she said, I have noticed the younger doctors are wanting the bowel prep, the fleet enema, but our older doctors don't order a bowel prep.
It's interesting. So some changes. I did actually ask about if you require a bowel prep, what do you use? And the Fleet's enema was by far the hands down leader, almost 90%. We did use Go Lightly in the past. Patients, anybody who's ever gone through a colonoscopy, you know what that stuff is like. It just, you come in, you're just like out of it. It really makes you, it comes out clear out coming out as it goes in. So it's really way overkill. A Fleet's enema, although I have had some patients complain that it's difficult to give yourself an enema and it's difficult to get the neighbor next door to come over and give it to you. But
hey, if you pay them enough, I'm sure they will do
it.
Yeah, who knows? If you're lucky enough to live next to a urology nurse, maybe they'll have some compassion and come over. So who knows? But,
I will not be doing fleet enemas on my neighbors.
All righty, let's go on to our next thought here. Anesthesia, oxygen, nitrogen, I'm talking about different types of things that we use. And I asked, so do you use anesthesia for your transrectal biopsy? Surprisingly, to me, at least 13% say none. Maybe not so surprising. If you're not doing it right, you shouldn't be doing it at all because it just adds to the discomfort. But most are giving a prostate block. Some are using nitrous oxide. Some are using a combination of nitrous oxide and a local block. A few out there doing general anesthesia. So kind of a variety of different options for that. Let's bring it up to the panelists. What are your thoughts on that? Lori, what do you guys do? And well, you're sending them off to the OR, right? Because you're doing transperineal.
Yeah, but when we were doing them in the office, this was many years ago. Obviously, in the beginning of my career, there wasn't even a local block. I mean, so then they started switching over the local block, and that's pretty much all we did in the office, at least in our office.
Yep. John, your thoughts?
So much of what we do in the office after we go through training is, well, that's the way we used to do it. So that's also known as status quo bias, or I like to call it dogma. We do it this way because that's the way we've always done it. I always like to challenge things, and you can do it however you want, whatever is comfortable for you and the patient. You can do it without any local or prostatic block. You can do it with nitrous oxide sedation. You can do it with IV sedation, either in the office or in the OR. It really depends on the comfort of the urologist performing the procedure, or APP in some cases.
Yeah.
And the patient. Some patients are just super anxious. For instance, I used to use viscous lidocaine for all my in-office cystoscopies, especially males. Now I can't remember the last time I had to use viscous lidocaine for cystoscopies for males, because you get better the more you do. The verbal anesthesia that you can provide gets better. Your technique is better. You know when to slow down, how to talk to the patient during the procedure. It's like a 2-minute procedure, and to go through a whole big ordeal for a transrectal ultrasound biopsy or just cystoscopy, I think it's overkill. Those patients who are really anxious, some will request an oral benzodiazepine. We commonly use nitrous oxide in the office. And for the super anxious guys, then IV sedation in the office usually does the trick.
Yeah. Good point on that. Yeah, we had in the past, we tried, some patients with Valium or Xanax, but sometimes, some patients, it doesn't really affect at all. Other patients, you can hardly wake them up. It really knocks them out. And I get worried about, them stumbling on the way back to the car and falling. So the nitrous oxide, like you said, if they request it, it's a great one for knocking the nerves down a bit and wears off so quickly that they're, walking out pretty much the way they walked in. So it's a good option. We were part of the group that was doing nothing years ago before the transrectal block was really, I think, more perfected, where they were giving it properly. We used to do some blocks, but it didn't make any difference. We had some urologists, the old timers, said, there is no sensation in the rectum with the the needle. So they said, no, you don't need to give a block. Well, I can tell you that I assist on many, many, many of these, and patients do really well with a good block. I mean, some of them, if you get them through the nerves, as John kind of said, don't underestimate what a good conversation will do. We've been doing that for years, where we talk about something, anything. Sometimes it's, I live in the Chicagoland area. You can talk about the Bears right now throughout the season. Everybody's got an opinion about that, and get their mind off of what you're doing. And I've had a few patients call me on it at the end of the biopsy, and they'll say, you guys did that on purpose. You got me going about this. And he goes, I didn't even know you were doing the biopsy. Quite frankly, we were so busy with conversation. So that's always a good one. And my other trick is something called yacht rock. That's a genre of music. This group that's coming in for biopsies are all from that era. You start putting on the songs. I got people that are singing to the songs that I got playing in the background, and anything that takes your mind off of it is great anesthesia. Any comments from the live audience?
Not at the moment.
All right. Hey, live audience, you're free to put anything in you want.
And
all right.
For those thinking about using nitrous oxide, there are essentially 3 different systems out there. I actually have a Pronox machine here in the office. I have a Nitronox Plus, which I really, really like. And then also NitroSeal is another option out there for in-office nitrous oxide. It is a cash service, and it's not really by request of the patient. We offer it. We will say, hey, if you're anxious, if you're feeling skittish about this procedure, we do have nitrous oxide. You do not need a driver to bring you here and drive you home after using nitrous oxide. Unlike benzodiazepines or diazepam, Valium, we require someone to bring you here and take you home. So you're incurring additional cost to the patient. This other person who has to drive you will not be able to work, will not be able to be productive in society or do what they want to do, because their time is going to be tied up driving the patient to and from the biopsy.
Yeah. We do the same thing, offer it to patients that want to, because again, it's a cash call. I've told patients, sometimes the patients can't stand the prostate probe going in just for the initial measurement. They're really getting nervous. You kind of know those are the patients you're going to have a hard time with. We can just turn it on like that and, get the setup for the Pronox to give it to them and kind of give them as an option. Hey, listen, if you want, you're really anxious, I can see that. Why don't you try this? And sometimes it's nice to have that. I have a question for you though, John. You said you like the other option over Pronox. Can you explain a little bit what's the difference between the different nitrous systems?
Let me go back a little bit. First of all, you can identify the anxious patients when you perform that transrectal digital rectal examination. Using a digit. It's not some instrument. So digital rectal examination, you can already tell that the patient's going to be, okay, this person may need a little bit of additional sedation. When they raise their heels and then start just tightening everything in the perineal area. Yeah, those are the kind of patients you want to offer diazepam or nitrous oxide. Here's something this is what I tell the patients when I ask them to, okay, I want you to this is what I do. I want you to bend over and put your elbows on the table. So I physically demonstrate that to the patient so that they feel a little bit more comfortable being in that position, because I've actually done it. They've seen it. Number 2, when I'm actually doing the digital rectal examination, I tell the patient, this is the worst part of my job other than dealing with insurance companies. So I'm taking their mind off of what I'm doing so that they can kind of give me a little bit of empathy. So the device that I use, I had 2 Pronox machines, and I gave one to a local urologist because I've got now a Nitronox Plus and a Pronox. I like the Nitronox Plus because I have the ability to adjust the amount of nitrous oxide concentration. So the ability to dial it down or dial it up while you're providing the nitrous, I think it's helpful for some of the longer procedures, or some patients who are saying, I'm not feeling much, or, that's a little bit too much. it's adjustable. The concentration is adjustable. I also like Nitronox Plus because similar to Pronox, it's on demand. On demand, meaning unless the patient is volitionally holding the tube, forming a good seal around the tubing and taking a breath, he or she is not getting the gas. That means you don't have to watch as much for the fugitive emissions. Granted, anytime we're running the nitrous, we have an exhaust fan running. So for any sort of exhale gas, first of all, I never tried Nitronox or Pronox myself. Never tried the gas myself because I don't want to get high on my own supply, right? I have total access, free access. So I never tried it. And I never felt the effects that are described by the patients, lightheadedness or dizziness or tingling in your fingers. I can't have tingling in my fingers since I'm doing a vasectomy. So I never felt the effects of nitrous oxide from exhaled gas from the patient. And I like the on-demand aspect. I like the fact that you don't have to plug into a wall. I like the fact that there's no scavenging that I have to deal with. I like the fact that it is portable. So if you have multiple procedure rooms, you can roll it into each one as necessary. I have 2 procedure rooms, so I have a Pronox machine in one. I have a Nitronox Plus machine in the other. And I personally currently prefer the Nitronox Plus.
So the Nitronox Plus allows you just to dial it up a little bit more nitrous.
Yep. You can
Pronox is a 50-50 mix, right?
Correct. Pronox is fixed 50-50.
Yeah. So that's a good point because we have had patients that said, it's just not working. It's not working. So you kind of wish you had a plus button you could push and just give a little higher. So good point.
Being a little bit of a geek, I like the dials. I like to see the actual mixture dial. I like to see the oxygen pressure. I like to see the nitrous pressure. That's all on the Nitronox Plus. And also Nitronox Plus is very much more user serviceable than the Pronox machine.
Good point. All right, great. All right, next question was, who assists you with the transrectal biopsy? Kind of looking at who's doing this by themselves, or is it a nurse? Is it an MA? Is the ultrasound tech? And got some good information, and probably is no big surprise. More and more now we see medical assistants that are in assisting for the procedures that were more in the past done by RNs. I think it varies practice to practice. I would say the only thing that I would add as a comment on myself is what I've noticed is with medical records switching over to EMR, most of us I think are on EMR now. We tend to rely more on the patients filling all this information out ahead of time, and it gets populated in our EMR. And I find that, and again, at our particular place, I'm the RN that's pre-op the patients, and I'll go and I'll look at the records, and it'll say no allergies. Oh, I'm allergic to penicillin. I'm allergic to latex. It's all these things are not getting picked up. They don't realize it. And I'll look at the medication list, and there's blood thinners that they're on that are not found. So, caution, whoever's assisting, make sure that they're double checking what the patients are putting in that chart. Any thoughts from the experts on that?
Well, hopefully you catch the anticoagulation when you're talking to the patient before the day of the biopsy.
You should.
That's how you are able to detect that they're on blood thinners and provide appropriate pre-biopsy instructions, which is imperative.
Yeah, our medical assistants, when the patient arrives, will re-ask those questions if they've stopped their blood thinners and things like that, so that it's caught before we do anything.
Yeah, I feel bad for patients that get canceled because I'm the one who discovers they're on blood thinners the day of. It's just crazy.
I'm a little anal retentive, so every biopsy, and I will ask the patient while he's already positioned and stuff like that. So, Mr. Jones, what is your name? Or I'll say, hey, what is your name? But without saying his name, what is your name? Can you tell me your name? And also, what is your date of birth? And as he's telling me that information, I will look at the ultrasound machine, make sure the name and the date of birth matches. I will look at the actual biopsy jar and make sure the name and the date of birth matches. And there's only one requisition form in that procedure room during that biopsy, because it would be horrible if you screw up that chain of custody for the biopsy and you have the wrong patient's label and samples placed in the wrong jars.
Yeah. And that's what I would want as a patient. I want my practitioner to be anal retentive, that every step has been followed, because it's really important that nothing gets missed. All right. Let's see. My next one here is talking about the equipment that we use for transrectal ultrasound. So there's, on the left is the reusable, on the right is disposable. And I asked the question, what are you using? And probably no big surprise now, most of us use disposable, one-time use, use it and toss it. But still about 17% of the people who participated said that they're using reusable. And the reason I was looking at that was I was part again of that white paper. And there was one of the things I found out when I was looking at the risk of infections was it had to do with reprocessing of the equipment. And what they found is these infections were being caused because the brush that was supposed to be used to clean out the needle guide wasn't being used because it was sold separately and they never bothered to buy it. And this is a picture that I used as a demonstration. We use disposables now, but before, when we used a reusable, here's our guide. And I pushed out with the brush that long clot that you see there. So even if you sterilize this through an autoclave, the first step to any kind of reprocessing is to make sure that you have it thoroughly cleaned, because you can't go ahead and, sterilize that big old clot of stuff in there. And that's why they were getting these infections. All right.
Yeah, just like any equipment, the gross decontamination should be done first, and that's part of the gross decontamination. Getting rid of the big things that you can see and anything that you can feel. You want to just get rid of that with the brush. Yep,
absolutely. So we talked about it before on reprocessing equipment. Check out some of those episodes that I did on our talks. The next thing I asked about was the type of biopsy guns that's used. There's disposable now and there's reusable. Most, little over half are doing the one-time use. Some are still doing the reusable metal ones. Again, those would have to be reprocessed. Any thoughts on which ones you're using, or I'll ask the experts what you're using in your group? We use the disposable now, and it really was kind of almost not much choice, because Bard quit. They used to have a thing where they would reservice the equipment after, if it failed, for like no cost, as long as you use their needles. Well, then they quit even reservicing it. It was, you had to buy a new handle, and that cost, when you started adding it all up, was cheaper to buy a all-in-one system. So that's what we're using.
As of last year, or maybe 2 years ago, when I had to send in my Bard Magnum, it's called the Bard Magnum biopsy device, which I prefer. It is much faster, much more efficient in doing prostate biopsies using the Bard Magnum device. I actually created a video on YouTube. I'll put it in the comment section for our StreamYard viewers, discussing how I use it with one hand. I can perform the biopsy using that device with one hand.
Yeah.
So efficiency is key, no matter what you do in urology, in the operating room or in the procedure room. Bard Magnum, the best way to go. If you just watch the video, I show you how I use it with one hand. And when I'm doing a biopsy, the medical assistant is assisting me and helping me doing the biopsy. I will, using one hand, cock and prime the biopsy device, take the safety off, do the biopsy, open up the sheath, deliver the specimen while the medical assistant is holding that square. And here's the pro tip. Some urologists will hand the device to the medical assistant, and then she will open up that sheath and then deliver the specimen on a square. All that handling of the device, number one, inefficient. Number two, that device has a needle at the end. That's a weapon. So I try not to point weapons, just like a firearm. You want to point in a safe direction. So the less you have to point and handle the device, the better. I have the medical assistant have that square very close to where the needle exits the biopsy guide. So I simply withdraw the needle, open the sheath, move a few centimeters, deliver the specimen. Keep in mind, I'm using this one hand, and then I prime the biopsy device, reintroduce it into the sheath, take the safety off, and perform another biopsy. Very, very efficient. The entire process should take you less than 10 minutes for the measure, to getting the probe into the patient, measure the prostate, taking images, for medical, legal, and also for billing purposes, performing the biopsy and then walking out of the room should take you less than 10 minutes if you're doing it efficiently. So always think of ways to do it better next time.
Have you had much issue with the gun failing though?
It is rare. So here's another thing. The bar magnum device is pricey. I think now, last time I checked, under $2,000.
Mm-hmm.
You can buy broken ones. You used to be able to buy broken ones off of eBay. Send it into BARD, and then you do have to pay for its servicing. I haven't called BARD recently to see if they will still service the bar magnum devices, but that's what I had to do. I ended up with a bunch of bar magnum devices, fixed them, and shared it with the folks on the Thriving Urology Practice Facebook group, and then I sold them.
There you go. Lori, what's your group doing?
Well, when we were doing biopsies, it would definitely be all disposable. It's all disposable. Yep. And then let's go to April.
Anytime we think about disposable, like the disposable ureteroscope, disposable cystoscopes, for those who are environmentally conscious, that's a lot of waste that you're just single use and then you're getting rid of it. Granted, I understand the convenience, I understand the potential for decreased infection, but biopsy guide, when appropriately cleaned, sterilized, I think poses a very, very low risk.
Yeah.
Go ahead.
April said we only use reusable if the patient has an allergy to latex. The non-latex condom cover only fits the reusable needle guide.
Good point. All right. And now our last subject here before we call it a day. PSA, DRE. We know those are kind of the gold standards for what gets you into a prostate biopsy, an elevated PSA or an abnormal digital rectal exam. But in today's day and age where we're trying not to overdiagnose prostate cancer, what else is out there? So I did ask, what testing are you utilizing prior to biopsy? And of course, we found DRE and PSA being the most used, followed by things like PSA free and total, ISO PSA, 4K score, MRIs. So a large variety of different options out there. But we know PSA is not specific to cancer. It can go up because of things like BPH, prostatitis, UTI, age-related changes based on things like that, size of the prostate. We want to avoid unnecessary biopsies. Things like MRIs can help guide our biopsy strategies. So with that, let's bring our experts in for the last time for some thoughts. Pre-testing PSA, DRE, still kind of the number one test everybody I think would be agreeable. Do you have, what's your second line? What's your thoughts on that? Lori, what is your practice doing as a
We do a lot of PHI testing, but we definitely do a lot of prostate MRIs prior to biopsies, almost always actually, to look for those lesions and so forth. So yeah, but definitely PSA, DRE, and then usually a prostate MRI, PHI possibly, and then biopsy if needed.
Gotcha. John?
Yeah, I'm pretty cost conscious. So initially, when just a patient yesterday comes in with a slightly elevated PSA, so of course you look at the patient, look at the history. Is he African American? Is there family history? What does the rectal exam feel like? Also, the actual value of the PSA, how high is it? You know, it's like a 4.6 in a 73-year-old guy. Well, some people may say that age adjusted, that's normal. First thing I do is get a good history, do a rectal examination. It's the guy on testosterone replacement therapy. It could be a younger person on TRT. I can't tell you how many times I have them stop the testosterone for a month and the PSA magically comes down to normal. Even though some studies say, oh, it makes no difference. I see it over and over and over again. So getting a good history and then repeating that PSA, possibly adding a % free PSA if one wasn't initially done. Typically, that is not done because the primary care is usually the one performing that initial PSA. So getting a good history, doing the rectal examination, repeating the serology, and if that comes back abnormal after shared decision-making with the patient, request possibly a prostate MRI and then talk to the patient some more. Hey, this is what the MRI shows. Do you have some PIRADS 4 and 5 lesions in these areas or this area? We should consider doing a prostate biopsy. That's when I have that prostate biopsy discussion. So the short answer is repeat serology, prostate MRI, and then consider prostate biopsy after sure decision making.
Yeah, I like that approach a lot. And I think it's, I can remember in the old days, because I'm an old timer, elevated PSA biopsy, abnormal DRE biopsy. I mean, either one, it didn't matter. Anything that was elevated, you biopsied it. But we way over biopsy. We have a lot of Gleason 3+3s out there that are just now being observed. I mean, it does make sense. We've got these tests to use some of these. So, all right.
Vic,
well,
you guys have been around long enough where you probably remember transrectal digital finger guided biopsy. You remember those?
Yep.
I said those were always really brave urologists.
Yeah, I found them during training.
Yeah.
Oh my gosh.
Every now and then I would see where one would actually puncture the glove and still miss his finger. And I'm like, yikes.
That's
All
crazy.
right. So this has been a great discussion. I hope everybody enjoyed it. I really like these kind of quick surveys and then talk about it with the experts. I get to utilize my experts more efficiently this way. So it's great. But I've got a little plug for next week's show, which is going to be live from SUNA.
Come meet and greet the experts from UroNurse at the SUNA Urologic Conference on Saturday, September 28th at 9:30 a.m. Vic Sinise, Lori Atkinson and Andrea Strom will all be there live. This is a fantastic opportunity to connect with urology professionals who are passionate about education and patient care. Whether you're a nurse, associate, or simply interested in urology, you'll have the chance to ask questions and gain valuable insights from the UroNurse team. Join us as we stream our live show at 10 a.m., where we'll be discussing the latest in urologic care, patient stories, and a behind-the-scenes look at the conference. Plus, we'll be giving away exclusive UroNurse merchandise to 2 lucky people attending in person, so make sure you don't miss out on this exciting event.
Yeah, we're going to be live from the SUNA conference in Orlando, weather permitting. I've heard there is a hurricane threatening the coast, but we're going to try to make it in there. Looking forward to getting together with Andrea and Lori for this live. And remember those times I gave were Eastern time, because we'll be on the Eastern time zone. We're still going to be coming to you at 9 o'clock Central time for those of you that are on different time zones. And that if you're going to be there, hey, stop and see us. Say hi. We'd like to meet and greet some of the fellow urology folks that are going to be at the SUNA meeting. So we're going to have a little meet and greet a half hour ahead of time. There'll be information once I find out where they're setting up our table. It's supposed to be somewhere in the area around, I think, reception area. I mean, the place where you go to get your stuff from SUNA. So anyway, we're looking forward to that. As always, good to see you guys here for the duration. And we enjoyed this nice talk. That's all I got. We'll see everybody next week live from Orlando. All right. Have a great weekend, everyone. See y'all next week.
Thanks for joining us. Have a
Bye.
great weekend.